We now have some time for questions and answers with the panel. You're welcome to put the questions in to us. We will be able to see them here, and we can then answer those questions and have a bit of discussion about what you think is important in this. Happy to take them from the floor. Microphone 1.
Yeah, my name is Dr. Stassen from Belgium. My question is whether there are any formal cost-effectiveness analyses done or published showing that because you have to convince policymakers and insurers, the only way to do that is to publish a very good cost-effectiveness analysis.
Well, we have done studies of single time point ECG screening where we used a cost-effectiveness analysis and showed it would be likely to be cost-effective. I'll ask Renata to handle this because part of our studies, at least for AFib screening, showed it would be cost-effective.
Yeah, and we indeed, together with Dr. Friedman, we did it in a population-based setting, invitation, single time point screening, and there this very simple measure was cost-effective. It was not cost-effective to do an upfront NT-proBNP screening due to the comparatively high costs of NT-proBNP measurement. But what has been shown, this is observational data, but what has been shown in the randomized trial of a stroke stop study of a population-based systematic screening in individuals 75 years and older, they could, in a formal and hard outcomes-based health economics analysis, demonstrate that there is a benefit, a cost benefit, at 3 years after screening.
Okay, thank you.
We've got a question at microphone 2.
Hello, Rick Willems from Leuven, Belgium. Do you think we'll ever skip the ECG and rely on PPG only? It's my first question.
Say that again.
Do you think we'll ever skip the necessity of an ECG and rely on PPG only?
Well, if you ask my opinion, not yet. If you ask the opinion of the ESC Guideline Committee, the American Heart Association Guideline Committee in the last year, both say no, not yet. If you want to make the diagnosis of AF, which will have lifelong implications, potentially atrial fibrillation, for treatment with anticoagulants, they require a diagnosis of the ECG. That's at the moment.
Yeah, but sensitivity and specificity of a single lead ECG strip is, in some studies, not or as bad as a PPG diagnosis.
It depends on what you're looking at. If you're looking at the algorithm, you're probably correct. But if you're looking at an expert reading of it, that is how you make the diagnosis. And unfortunately, that's the gold standard. And I don't see it changing immediately myself. Renata, I don't know about you, if you think that we will be able to go away, but everyone I've spoken to who deals with guidelines says no.
Yeah, for now, the evidence and the guidelines are against using PPG only. But I always look towards the future, and I think we have seen a tremendous improvement in the algorithms. And Dr. Friedman has shown how also these blood measurement devices-based algorithms, how they have improved. And so I'm still optimistic that at one day we will be able to distinguish atrial fibrillation from a PPG.
Thank you.
Thank you very much. There's another person behind. Please state your name and where you're from.
Thank you very much. Dr. Marco Zavatta from San Marino State Hospital. In our small country, we had an experience of opportunistic screening for atrial fibrillation during a screening for blood pressure being performed by a charitable organization. And we, as a National Society of Cardiology, gave availability for performing an interpret formal 12-lead ECG when the screening method gave positive results for atrial fibrillation. We had to stop this experience because of the number of false positive and the workload in terms of interrupting our activity to perform ECG in patients screened, especially during holidays and weekends. We were constantly interrupted by people who didn't know what to do with the positive response of the screener for AFib. And we had zero newly diagnosed cases of atrial fibrillation. I think this was a device problem, but this has to be solved, because otherwise for small organization it would be very useful, but it's impossible to perform. Thank you.
I think you've brought a real important point. When we're doing population screening, specificity is crucial, and it depends on the population. If you are younger, you'll have more false positives. Also, handheld ECGs are much more transmissible, quicker and easier to do, and would be one way of getting around the problem of a 12-lead ECG for diagnosis. But doing this in the community is a problem if you don't have a pathway to action, both to treat the high blood pressure if you find it and to treat the AF if you find it. So just looking for it creates more work sometimes, but also you need a pathway. I think, Alta, you would agree with that.
Yes, I fully agree with that. And what is quite interesting with your study is that's exactly what we want to avoid with the screening, right? You want to have a relatively good screening approach with an easy, two-in-one device with enough sensitivity and specificity so that at least a large proportion can be confirmed with ECG. So it probably depends on the devices, and as has been mentioned, the devices' quality are improving. So I don't think you should stop yet. I think we should go again and get a better device next time.
We won't stop, right?
We'll take your question in a moment. There's one that's come through for a little while. Please stay at the microphone. We'll take your question, and we'll take one from the audience on the...
So there's also questions from the online audience. The first one from Julian Lugo Peña. What is the best screening tool in daily practice? 12-lead ECG and 24-hour Holter, or both are not sensitive enough? That's a very good question, and for screening we have to be very effective and efficient. And we've just learned that the right device, the right algorithms, and the right method to screen is. And for now, we have these very nice data. If we want to do a systematic screening in the community, as I understand it from this, is that we could do an intermittent screening. We don't need to have a Holter, but a handheld device, single-lead device is sufficient. If you want to do an opportunistic screening in clinical practice for hypertension and atrial fibrillation, you should probably use the devices that you are familiar with and have in your practice, and the usual 12-lead ECG is completely sufficient, and for opportunistic screening, it would be a single time point screening. You can, in practice, also do a single-lead ECG, which is easier and is much faster to be done, but not all practices currently have this.
Yes, sir. And the question that was raised about paroxysmal AF, which you may miss, there's still debate, an open debate about how intensively we should look and whether that's worth doing for picking up the paroxysmal AF. So I won't enter into that at this moment. We're looking more for AF that you could find on a single time measurement. Please, number two.
And Neil Herity from Belfast. I want to go back to the clinical trial evidence that screening for either atrial fibrillation or hypertension improves clinical outcomes. So we saw one clinical trial presented today. That was the LOOP study, which showed no benefit. And there were two contradictory trials about opportunistic detection of atrial high rate episodes in people with pacemakers, which were contradictory. So at the moment, as I read it, there is no evidence that screening for atrial fibrillation improves clinical outcomes. But the other thing is, I didn't see any clinical trials presented today answering the same question about hypertension. So have there actually been clinical trials where one population is randomized to hypertension screening, another to no hypertension screening, and clinical outcomes followed up?
I'll get Alta Scooter to address your second question. I take issue with your first comments, and that is that the Artesia study showed a benefit, and in meta-analysis of both Artesia and NOAA for device-detected atrial fibrillation, there was a benefit that was significant. In a conventional study-level meta-analysis of both loop and stroke stop study, it just reached significance. But I agree, it's a little bit harder for those studies. In single-time screening studies, there has been no proper randomized trial that was powered to look at stroke. The thing is that if you look at single-time screening, you need to know that the US PSTF, the United States Prevention Task Force, do not call this screening. They call it case detection or good practice. They don't regard it as screening. But if you look at the stroke rates of those people when untreated, it's identical to those with known AF. So if you are detecting cases by opportunistic screening, it might be called opportunistic case finding, then it's just good clinical practice to treat them. Alta, would you like to take the question about trials for BP?
Yes, thank you. I think that's a really important question that we always ask ourselves when you do these massive screening campaigns for blood pressure as well. And for us also the key is to make sure that there's a pathway to care, that when somebody is detected that something actually is done in terms of their blood pressure. We know that blood pressure reduction is strongly related to outcome in many trials, so it's about detecting them and getting them into that care pathway. But there's been a study done in China in terms of screening that have shown that when detected and also when ensuring that they enter the care pathway afterwards, that it did reduce blood pressure significantly 2 years later. So yeah, it's a big challenge actually to collect that type of data and to follow people that were screened in general, but it's truly important question.
So thank you very much for that question. I think we've run out of time.
Yeah, there are many more questions online, but I think we do not have much more time. Maybe it can bring up one other question, which also is relevant. How long do we need atrial fibrillation to define risk for treating with anticoagulation? And maybe I can here say something about the current guidelines. In the guidelines, we left this 30 seconds ECG diagnosed atrial fibrillation because it was completely artificial this time, and we say that if you are able to diagnose atrial fibrillation on an ECG, that this is atrial fibrillation, and then the care pathway starts that you need to look for anticoagulation and comorbidities, etc. Ben, do you want, because this also relates to the Artesia NOAA studies and the LOOP study, do you want to add on this?
Yes, I think that I don't think we will find a magic time cutoff because it relates very closely to the other risk factors for stroke as to what will be important. The only thing that's quite certain is the higher the burden, the more likely you are to have an adverse outcome. But I think finding a magic number has not yet come from both NOAA and Artesia.
Can I just make one additional comment to that? I think burden will be important in the future. And everybody should understand that if you find AFib on a single time point, that person probably has high burden. And if you find AFib in device-detected AFib where it's there 24/7 and it's a little bit, they probably have a very low burden. And the only other point is, of all the sub-studies of NOAA and Artesia, the one thing that was helpful was the CHADS-VASc score. If you have a CHADS-VASc of 5 or more, there was a more significant benefit of anticoagulation. And if the CHADS-VASc was 3 or less, you really don't have any benefit. So I think clinically that helps us a little bit.
Yes, there is a big overlap, and you need to take the age and the risk factors into consideration at the same time as the duration and the burden of AF. But I think there is a signal there. We'll hear more about that at this meeting with more sub-studies of both NOAA and Artesia. And I'd like to thank the sponsors for organising this meeting. I'd like to thank my colleagues, Renate Schnabel and Alta Scooter, for an enlivening debate and discussion with the audience and with those people online. And thank you very much for your attendance.